My name is Lily Gumnarova, and I will discuss brainstem gliomas in children and their management. The objectives of this presentation are outlined below. I will briefly discuss the subtypes of brainstem gliomas in their clinical presentation. Given the rapid advancements in understanding the biology of brain tumors, I will summarize the available knowledge regarding the molecular background of these tumors. Based upon this, I will focus on how our management has been influenced. This includes targeted surgical management based on understanding the biology of the tumor and how it affects surgical approaches, goals, and extent of surgery and techniques. I will also discuss targeted therapies for gliomas and the development of novel drug delivery modalities such as convection-enhanced drug delivery and alteration of the blood-brain barrier in diffuse intrinsic pontine glioma, as well as the role of biopsy in these tumors. Finally, we will present an algorithm for the management of brainstem gliomas. Brainstem gliomas account for 10 to 20% of all pediatric central nervous system tumors. They're classified into two main groups: the focal brainstem gliomas, which include dorsally exophytic gliomas, tectal gliomas, midbrain, and cervicomedullary gliomas. The majority, or 80% of brainstem gliomas, are the diffuse intrinsic pontine glioma, and based on their genetic abnormalities are now referred to as diffuse midline glioma H3K27M mutant. There is no specific age distribution. Patients with neurofibromatosis type 1 frequently have brainstem lesions, presumed to be low-grade gliomas, and these have a biologically indolent nature and do not require intervention unless clinically symptomatic. Focal brainstem gliomas present with symptoms and neurologic abnormalities based on their location. Those are usually minor and often of long-standing duration. Torticollis is seen both in infants and in older children with exophytic tumors and is due to chronic tonsillar herniation. Medullary gliomas often present with dysphagia or apnea. These symptoms are frequently of long-standing duration and can be misdiagnosed. Cervicomedullary gliomas usually have a combination of both upper and lower motor neuron lesions given the anatomy and location of the tumor. Hydrocephalus is the classic presentation for tectal gliomas and can also be seen in the dorsally exophytic gliomas. Imaging of focal brainstem gliomas is with MRI. These lesions are usually well demarcated as seen in this panel of images. There is no or minimal edema, and they have the classic features of low-grade lesions on MRI, ISO or hyperintense on T1 weighted images, and bright or hyperintense on T2 weighted images with homogeneous enhancement. These images are from a patient with a midbrain pilocytic astrocytoma who presented with an isolated cranial nerve abnormality. She underwent resection and adjuvant chemotherapy with vincristine carboplatinum and is alive without any evidence of disease and neurologically intact more than 10 years after completion of treatment. Tectal gliomas are a unique group of focal brainstem gliomas. Long-standing obstructive hydrocephalus is the most common presentation, and unlike other tumors in that location, such as pineal germ cell tumors, they most often do not have cranial nerve involvement. Tectal gliomas are poorly demarcated and rarely enhance. As you can see on the panel of images from several different patients, the tumors are hypointense, on T1 weighted images and hyperintense on T2 weighted images. Of note, tumors with volume larger than 10 cubic centimeters are associated with worse clinical outcome and prognosis. Dorsally exophytic brainstem gliomas have a characteristic growth pattern arising from the subependymal glial tissues. The main bulk of these tumors usually resides within the fourth ventricle, but may extend into the cerebellopontine angle and cause compression and displacement of the lower brainstem. They have the appearance of low-grade gliomas on imaging with similar enhancement and imaging characteristics as described earlier for focal brainstem gliomas. This panel of images shows such a tumor in a 2-year-old male who presented with swallowing difficulties. He underwent subtotal resection of a low-grade tumor, likely pilocytic astrocytoma, followed by 2 courses of chemotherapy, vincristine carboplatinum and TPCV for progressive disease soon after the initial surgery and diagnosis. He is now 18 years of age, has no neurologic deficits, and there is no evidence of disease on imaging 10 plus years after completion of therapy. Most focal brainstem gliomas are either pilocytic astrocytomas or fibrillary astrocytomas. They have variable degrees of cellularity and atypia and are generally non-invasive with a low mitotic activity. Nowadays, it is critical to test for the known genetic abnormalities we see in gliomas in children, specifically for the duplication fusion BRAF KIAA1549, as this is seen in the majority of juvenile pilocytic astrocytomas and can aid in choosing targeted therapies. Additionally, mutation BRAF V600E has also been noted, although less frequently, and there are also targeted therapies directed to this abnormality with some good early clinical results. Management of focal brainstem gliomas can be tailored to location and biology. Most upper midbrain and tectal gliomas present with obstructive hydrocephalus. Endoscopic third ventriculostomy is the preferred method of treatment, but if not possible, placement of a ventriculoperitoneal shunt can be performed. There is no need for biopsy of the tumor, as usually it is not exophytic into the third ventricle. Biopsy can be associated with neurological deficits and insufficient tissue, and these tumors usually have an indolent course. If there is any concern about the tumor pathology, a stereotactically guided biopsy can be performed. One can also sample the cerebrospinal fluid for cytology, as well as for markers of pineal area tumors such as AFP and beta-HCG. Small tumors with typical imaging do not require adjuvant therapy and can be followed only. Larger, dorsally exophytic tumors of the midbrain may require surgery to debulk the tumor with the aims of relieving hydrocephalus, obtaining tissue diagnosis, and relieving neurologic deficits. Given the long-term good prognosis for pediatric low-grade gliomas, surgery should be performed with the goals of preserving neurologic function in addition to the above goals. As you can see in Figure B, this patient had an ETV and has excellent flow through the stoma with a complex residual tumor after surgery and multiple chemotherapy regimens, approximately 10 years after presentation and diagnosis. He is neurologically intact except for some limitation of upgaze. Tumors with volumes greater than 10 cubic centimeters, such as his, have a poorer prognosis and will frequently require adjuvant therapy. The dorsally exophytic tumors were the first group of brainstem gliomas to be treated with surgical resection, likely due to the growth pattern and easier access to the tumor. These tumors have an exophytic component, and the goals of surgery here are to relieve pressure on the brainstem, debulk tumor, open up the cerebrospinal fluid pathways, and obtain tissue diagnosis. As these tumors are infiltrative and arise from the subependymal glia, it is important to debulk from the center and not enter the brainstem parenchyma. Surgery should be performed with neuromonitoring tailored to the location of the tumor and involved structures. Intraoperative guidance and ultrasound are often of great value. This panel of images are from a teenager who presented with headaches and underwent subtotal resection of a pilocytic astrocytoma, followed by adjuvant chemotherapy with vincristine carboplatinum for residual disease. She is now stable with minimal amount of residual disease, neurologically intact 5+ years after completion of therapy, and is attending nursing school. For patients with progressive, inoperable, or residual disease requiring therapy, chemotherapy is the preferred adjuvant therapy for the focal brainstem gliomas. The well-known combination of vincristine and carboplatinum is the first line of therapy and has overall excellent results with achieving tumor stability in the majority of patients, as seen in the slide. TPCV has usually been the second line of chemotherapy. However, the new BRAF inhibitors are emerging as second or third line of therapy for pediatric low-grade gliomas. They appear to have less of the side effects commonly seen in the adult population and are overall well tolerated in children with promising results so far. Additionally, targeted drugs towards the V600E mutation are in clinical trials currently with some promising results, although this mutation is relatively uncommon in the brainstem gliomas in children. Radiation therapy can lead to prolonged progression-free survival in focal brainstem gliomas. However, given the long-term complications from radiation therapy, such as second malignancy and vasculopathy, it is usually reserved as a last mode of therapy. The diffuse intrinsic pontine gliomas, or DIPG, are the most common of pediatric brainstem gliomas, and sometimes people use these terms interchangeably. It is important to distinguish between DIPG and the other brainstem gliomas, given the differences in their biology, behavior, and outcome. Patients with DIPG usually have a very short history ranging from days to weeks. The classic presentation is the triad of cerebellar symptoms, long tract impairment, and lower cranial nerve palsies. Of note, the majority of patients with DIPG do not have hydrocephalus at presentation, and usually the development of hydrocephalus is a terminal event or at progression of disease. Imaging of DIPG is with MRI. As you can see on these panels, the tumors have indistinct margins and are iso or hypointense on T1 sequences. There are hyperintense on T2 sequences, but with some degree of heterogeneity, and similarly contrast enhancement is heterogeneous. The so-called classic features on imaging are diffuse expansion of the pons and wrapping of the basilar artery by the tumor. However, in multiple consensus meetings and surveys, there was significant discordance amongst reviewers consisting of neurologists, neuro-oncologists, neurosurgeons, neuroradiologists as to whether a tumor is a DIPG or another type of brainstem pontine tumor. Therefore, atypical tumors should be biopsied if feasible, whereas the typical appearing DIPG on MRI can be initiated therapy without pathologic diagnosis. Obstructive hydrocephalus and dissemination are uncommon at presentation. Nevertheless, all patients with DIPG should undergo imaging of the entire craniospinal axis at time of diagnosis. Recently, identical H3K27M mutations on 2 histone genes were identified in the majority of DIPGs, which led to the new nomenclature of diffuse midline glioma H3K27M mutant. This was adopted in the 2016 WHO classification of CNS tumors. There are multiple studies looking at these genetic abnormalities in DIPG and developing therapeutic targets, although still in early development. Additionally, multiple other mutations have been identified in other pathways, as you can see on this slide. One such mutation in the ACVR1 gene, which leads to the activation of the BMP-TGF-beta pathway, was also identified, and there are some targeted therapies directed to it that are in clinical trial. Unfortunately, so far, none of these have been successful, although there have been tremendous advancements in the understanding of the makeup of these DIPG tumors. This has been largely accomplished by a significant improvement in the surgical outcome of biopsy of these tumors, and multiple groups from both Europe and North America have shown the feasibility and safety of biopsy of DIPG. The management of DIPG consists of symptomatic treatment with steroids at presentation. Although surgical biopsy is not a requirement for the diagnosis of DIPG, it should be strongly entertained if there are atypical features on imaging and/or on presentation. Additionally, biopsy can be offered in centers where there is the technical and pathologic expertise to analyze the tissue, as this can advance our understanding of the biology of these tumors. Radiotherapy remains the only proven modality that prolongs overall survival in patients with DIPG. Convection-enhanced delivery with stereotactically implanted catheters is a novel form of direct drug delivery that has shown early promise. Additionally, studies on opening the blood-brain barrier in conjunction with CED are underway. Here I present our algorithm for the management of brainstem gliomas, and I will very quickly summarize it for you as we have gone over that in the presentation so far. After initial diagnosis with MRI, the patients are grouped according to location. Patients with cervicomedullary tumors, which are likely low-grade gliomas, should undergo craniotomy with a goal of safe radical surgical resection. The same should be performed for the exophytic pontine or medullary lesions. Patients with midbrain tumors, which are also likely low-grade lesions, are separated based on the presence or absence of hydrocephalus. Those with hydrocephalus should be treated with an ETV or shunting and adjuvant therapy as necessary based on the imaging and clinical features of the tumor. Patients with exophytic tegmental tumors may require surgery for debulking of the tumor. Patients with diffuse tumors likely have aggressive lesions and should be treated with radiotherapy. It is important in all of these to make sure the patient does not have neurofibromatosis type 1. In conclusion, brainstem gliomas are a heterogeneous group of tumors. They can be either low-grade or focal brainstem gliomas or diffuse intrinsic pontine gliomas. The recent knowledge on the makeup of the low-grade tumors, the presence of the BRAF V600E mutation, and the KIAA 1549 BRAF fusion with downstream activation of MEK has identified targets for drug development, and there are promising early clinical results. Hopefully, similar results will be seen with the understanding of DIPG biology. Improved surgical techniques and intraoperative imaging and monitoring have allowed better surgical outcomes and are changing the algorithms for the management of these tumors. Tissue sampling, convection-enhanced drug delivery, and disruption of the blood-brain barrier, either with drugs or ultrasound, are all areas of neurosurgical involvement and innovation. We, as neurosurgeons, are uniquely positioned to impact the outcome of these complex tumors with surgical innovation and understanding the biology of brainstem gliomas and the blood-brain barrier. Thank you very much for your attention.